We're going to start with the young, that's appropriate. And Peter Richmond, who's a paediatric immunologist from Western Australia, is going to talk to us about maternal vaccination. Peter, thank you.
Thanks, Lou, and thanks everyone sticking around for the last session. I'd just like to first acknowledge the traditional owners of the lands that we are all on and come from, and their connection to the country, and acknowledge their elders past, present and emerging leaders. So thank you. Here are my disclosures. I don't receive any personal remuneration, though I am on lots of different advisory boards, a lot of them for RSV. And today what I really wanted to cover, I'm not going to talk too much about the burden of disease in children under 12 months, but just to give you some facts, there was 80,000 notifications of RSV in children under 5 last year. Half of all the hospitalisations in children under 5 occur in children under 1, and it's the most common reason that they're admitted to hospital. And it's a very common reason for them needing to see a GP. So 1 in 10 children under 6 months of age who during the RSV season will have to see their GP for a respiratory infection due to RSV. So this is, as a paediatrician, I think is a bit of a game changer. And it's been a long time coming. The first vaccines were trialled 60 years ago and didn't work, and in fact made the disease worse, and that continues to haunt us even till today, with some issues that have occurred with RSV vaccines in seronegative older infants and toddlers. And really it's been the last 10 years that we've made the progress really understanding the molecular basis of the fusion protein of RSV, which, for those of you who aren't familiar, is analogous to the spike protein on COVID, and the need to stabilise the structure in its pre-fusion conformation to elicit neutralising antibodies, or to develop neutralising antibodies against that pre-fusion target, both of which have been done. And I think this also actually helped us develop COVID vaccines so quickly, because we had already learnt from RSV. So these are the current ATAGI recommendations for 2025. So a maternal RSV vaccine that I'll explain to you where it's come from and what the issues have been and how good it is recommended for all women between 28 to 36 weeks gestation to protect the infant for the first 6 months of life. We also have licensed and recommended monoclonal antibodies, but not on the National Immunisation Program. So although we immunise with monoclonal antibodies, they don't count as a vaccine, so they're not on the National Immunisation Program. Hopefully that may change, as it has in other countries. And this is recommended by ATAGI for infants whose mothers have not had a RSV vaccine in pregnancy, or who were vaccinated very late. And I'll show you why we need to, they don't get as good protection from maternal vaccination. Or if they're at risk of very severe RSV disease, and I've listed some of those. And also those children with those ongoing significant risk factors for severe RSV in their second RSV season. So essentially takes them up to almost 24 months of age. And those mothers where the vaccine may not work, so who are significantly immunocompromised or undergo plasma exchange or ECMO or something, which is a fairly small number of mothers, thankfully. So around the world we now have 2 products that are licensed in the Americas, Europe, some parts of Asia, and Australia and New Zealand, not so much Africa, and most countries have both available. Some countries only have nirsevimab available, particularly those in Asia, and very few countries only have the maternal vaccine registered. So these have all really come along at the same time. And what we don't quite understand, and I think Australia is going to demonstrate a good aspect of it, is how do we optimally use these together to have the biggest impact on disease. And I'm going to talk about some of the factors that I think are important in that. So why would we use a maternal vaccination? Well, we know that this is a good way of protecting babies from severe disease in early life, so RSV fits with that, and we've done that with pertussis, flu, and in low and middle income countries for tetanus. We know that actually mothers are more motivated to get a vaccine to protect their infants than they are to protect themselves during pregnancy. We've learned that from flu. And I think there are also benefits that we get some additional antibody protection in breast milk from being vaccinated, and because it's not it's a whole protein, you get antibodies against multiple different parts or epitopes of the protein. So perhaps is less likely to be subject to mutations in the virus, which have occurred with some monoclonal antibodies. And it's probably easier to implement in low and middle income countries where, in fact, most of the 100,000 children who die of RSV each year have lived. But monoclonal antibodies provide immediate protection, so within hours of being immunised in the hospital or the GP surgery, they will be protected, unlike vaccines, which take some time to develop. They can be alternative or a complementary strategy, which is what we're going for in Australia. In premature infants who haven't yet been vaccinated or have only been vaccinated within the last couple of weeks, and they don't have the IgG from their mothers, they can be used. And obviously they can also be used in older children and closer to the RSV season if needed. So they may be more amenable to seasonal vaccination. And maybe better parental acceptance. I think we weren't quite sure until we saw what happened in Europe, but actually very high coverage, and I think in Australia we found the same. So this was mentioned by Helen yesterday, I think. What are the mothers' attitudes towards RSV and the preference of maternal vaccination versus nirsevimab? Well, actually, you can see this circled, it's pretty equivalent. It's about 80% of mums are happy to have a maternal vaccine or a monoclonal antibody to protect their infants from RSV. So they don't really have, and I should say this was done by our PhD student Charlie Holland and was recently published. So certainly parents are now getting aware of RSV, and if you let them know what RSV is about, they're even more likely to want to get their child immunised or be immunised themselves. This was announced that we would be starting on our national immunisation program a comprehensive strategy to prevent RSV, the maternal vaccine funded through the Commonwealth on our national immunisation program, and monoclonal antibodies for those other indications by the states through state funding on the basis of understanding the benefit for children in their particular states. And we hope that this can be coalesced so that they're both funded by the Commonwealth, and I'll show you why. So we have been doing trials in maternal RSV vaccines for just over 10 years now. There has been 3 phase 3 studies of maternal RSV vaccines. Novavax, which missed its endpoint in its early study, and I won't go into that. But 2 more recent studies, one by GSK that was stopped about halfway through them recruiting their 10,000 participants due to a signal where they were seeing an increased number of premature deliveries in the maternal vaccinated arm and a number of deaths associated with that prematurity. And so that study was stopped, and that the sort of overall risk was recently published in the New England Journal and a follow-up in clinical infectious diseases this year. And you can see this difference, about 6.8% in the vaccinated group and 4.9% in the placebo group. So a significant risk factor. And this actually occurred really in low and middle income countries, particularly South Africa, during the Delta COVID wave. Although they have done a lot of analyses to see if they can directly link it to COVID, and that hasn't been the case. But this is what actually happened if you look at it epidemiologically. So there seemed to be an interaction with COVID, and perhaps that's something to do with non-specific immunity. If you don't get RSV infection, perhaps you don't have non-specific immunity against COVID-19. But they haven't been able to show that, so we don't really know. And it was effective against medically attended lower respiratory infection, i.e. bronchiolitis or pneumonia in young infants up to 6 months of age. The Pfizer vaccine is slightly different. It's a bivalent vaccine, so contains fusion protein from both A and B. And again, a large study that was completed, and I've presented here before the preliminary efficacy results that are now finalised, that was published a couple of years ago in the New England Journal. But there was a lot of interest in what about this preterm signal that was seen in the GSK study. And you can see here that there's no significant difference in the rates of prematurity or the rates of COVID in the mothers, but they both point in the same direction. They're slightly greater within the vaccinated group, whereas all the other maternal and neonatal outcomes, there's no difference, and they vary randomly according to that. So I guess the assessment of this, well, we need to look at this a bit further. And this data has now been published in the last couple of months. And what we can see here is that on the left you can look at the overall differences, but if you look in high-income countries, so this is European countries, Australia, including we were involved in the study with a number of other investigators, and the US and Canada, there was no difference, both 5% in both groups. And we see that the difference is really in those upper middle income countries, which is countries like South Africa and Argentina. And actually when you go down to the country level, you can see here on the left that really it was South Africa was the main contributor to this signal. And South Africa was one of the highest recruiting countries as a result of a number of sites and a well-developed infrastructure for doing maternal immunisation studies. However, in those countries where the vaccine has been licensed, introduced, including the United States with the VAERS surveillance, and recently published in Argentina, there's been no signal of an increased risk of prematurity. As I've said, the final analyses are really very similar to the preliminary ones that were published, and this was in the last couple of weeks. And you can see that against hospitalisation, in the first 3 months it's about 70%, much higher for severe disease, so clinically significant or requiring oxygen or admissions to the needing additional support of over 80%, that really persists out to 6 months, although some drop off in efficacy. And this also showed ongoing protection out to 6 months against just medically attended upper and lower respiratory infections. And this is not just due to the lower respiratory infections, so perhaps the breastfeeding may actually be giving some protection against upper respiratory infections as well, although clearly not as significant. And I think the other important factor is that the initial cohort was followed up to 2 years and there was no rebound. So preventing RSV in your first year didn't mean you got it more severe in the second year. So that's important to recognise. That's probably because they still get infected, they just don't get disease. And this is looking at what affected maternal transfer of antibody to the baby. Well, actually, if you look going through your gestational age of vaccination, so if you were born at 35 weeks or 34 weeks or 33 weeks, that didn't make any difference. The only thing that seemed to make a significant difference shown there is having less than 14 days from when mum was vaccinated. So there's insufficient time to get that transplacental crossing of IgG. So that's why we don't count a dose within 14 days to be valid and to protect the child, so they need to be given the monoclonal antibody. There has been one country that introduced Abrysvo, or the maternal bivalent vaccine, onto their schedule. It was Argentina. They hadn't registered any monoclonal antibodies, and they got good coverage, so 60%, varied significantly in regions from sort of 40 to over 70%, but importantly there was no safety concerns in the mothers, and they evaluated it using the test negative design that I think we've become familiar with influenza, and much more recently with COVID. There's been a lot of these sorts of studies, so looking at the vaccination rates in the infants who tested positive for RSV compared to those who tested negative. So this included just under 300 infants in each group, and you can see here very similar rates of vaccine effectiveness, not efficacy, from 0 to 3 months and 0 to 6 months, consistent with what's seen in the clinical trials. And importantly, this was particularly for the severe lower respiratory tract infection. So I think this is good news for using this vaccine in a program such as Australia is doing. So what do we think about when we're introducing this in the program? Well, timing was important. The UK had said, look, you should really give this vaccine as close as possible to 28 weeks, although the data would suggest that perhaps that's not necessary, but certainly it will mean that if anyone's born premature, where most of premature deliveries are after 28 weeks, it would provide protection. Australia, we have a very similar recommendation from the TGA, but we haven't specified any particular time. The US are more conservative because they were worried about the prematurity, so they've said 32 to 36 weeks. But certainly I don't think it'll make a difference, but I think from a programmatic point of view, trying to get in as soon as possible after 28 weeks makes a lot of sense. Interestingly, the European Medicines Agency recommended it from 24 weeks, which was what the study was done in. Now, what about year-round versus seasonal? The studies were generally done as seasonal vaccinations, so the attempt to maximise the benefit for babies being born close to the start of the RSV season. But we know that with flu, it's harder to get the coverage that you get with pertussis vaccine. So perhaps all year round might be easier to implement. And could it be cost effective? Well, the PBAC has said so. So that means that we can afford to give it to all mums all year round, although clearly if you're vaccinating a mother who's been born in October for most of Australia, they're not going to have a lot of protection 7 months later when the RSV season starts. So the seasonality is really important, and certainly in our tropics, having a year-round program makes a lot of sense. So Queensland, Northern Territory, Northern Western Australia. And I think it's also important that it can be given with maternal boosters, although there was some reduction in the antibody response to some of the pertussis antigens, but not pertussis toxin, which is really the one we're most worried about. I think that's reassuring. As I said, parents are accepting of maternal vaccination. One of the questions will be, though, is this what the US calls shared decision making? Do you sit down with a pregnant mum and say, look, we have 2 options. You can either have the maternal vaccination, which is being funded by the Commonwealth, or if you don't want to have that, you can get a monoclonal antibody immunisation when your baby is born. Or is it just saying, well, this is the vaccine you give and then you just have to mop up the ones who don't get vaccinated? I guess from the UK's point of view, they're only offering maternal vaccination, so that's all they can get. And the same in Argentina. The US has got that alternative approaches, and certainly I think starting a maternal vaccination program being announced just in February, I think we're going to have some difficulties getting coverage sufficient to protect most of our vulnerable infants by May or June. Interestingly, the coverage in the UK has just been updated for their first month of the program, was about 34%. So we need to do some work if we're going to get up to the 70% that we see with pertussis. And clearly there's this overlap that we have to discuss, and I think everyone would agree it's parental choice. It's about how we give them that choice and how we inform them about it, I think, is the subtleties, and that may change between different states. Clearly we need to make sure our Indigenous children are covered, whether with maternal vaccination in the first instance or monoclonal antibodies, and obviously in the second year of life I think they're a high-risk group. We do know that prematurity, and this graph at the right shows the increasing incidence of premature children being born in the first half of the year compared to the second half of the year. And you can see how it might be different in terms of the benefit that they would get if they are born in September compared to if they're being born in April or May and then discharged in the peak of the RSV season. But nevertheless, always remember 83% of infants who are hospitalised are otherwise healthy. So what about monoclonal antibodies? Well, nirsevimab is the one that we have heard the most about, directed at site 0, which is the binding site of the fusion protein onto our respiratory epithelia. But there is also clesrovimab that has recently published some phase 3 data that I'll talk about that won't be available in Australia, we don't think, until 2027. It's due to be submitted to the TGA later this year. Similarly to the maternal vaccine, the effectiveness estimates, and there's a lot of data out of Europe from the first season, which was 2023-2024, were remarkably consistent, between 80 and 90% effectiveness in those children who were immunised. And they got very high coverages of over 90% in many parts of Spain, and also in France, where they had problems with neonatal immunisation with hepatitis B, for instance. So clearly it's well accepted. The United States had very low coverage, so I wouldn't point to that. And certainly it also had a significant impact on overall admissions to hospital for any cause with low respiratory infections of approaching 60% in Spain, for instance. So I think this significantly reduces the overall burden on hospitals as well, which is certainly felt by those at the coalface. This has just been presented at the ID week. This is the experience in Chile, which again you can see extremely high coverage with the newborn campaign and the catch-up campaign, over 90%. And you can see here in the green the infants who have been immunised in the eligible cohorts, both catch-up and newborns, compared to the older children who aren't eligible, where it's really a very similar RSV season to previously. So almost over 90% reduction in the burden of disease. So highly significant. So across many different settings, this is an effective way of reducing RSV. In WA, I was surprised at the end of 2023 that we hadn't yet signed up for a RSV immunisation program, being somebody who has looked after sick children with RSV for many years, and with Paul Effler and the Communicable Disease Control Directorate, the Health Minister decided at a fairly late stage, so announcing it in early March, that we would have an RSV immunisation program that would be starting in 3 weeks. So this is what it looked like. Basically, it was a 12-month cohort of children. The catch-up was children born after October in 2023 up to the 30th of April, and then anyone born after the 1st of May, preferably in the maternity hospital, would be immunised. And we also had a catch-up campaign for Aboriginal children, because we know that they're 2 to 4 times more likely to get hospitalised, and medically at-risk children with those risk factors that I previously mentioned in their second winter season. We did very well with the first 2 groups, I think, considering the timing of the campaign. Not so much for the children in their second year, unfortunately. So this is a breakdown of the figures, and you can see that the highest coverage was in the birth cohort, so over 80%, whereas the infant catch-up cohort was still pretty good at 66%, I think, for something that started so late. And I'd have to say the GPs and the midwives and community health nurses did a fantastic job. And you can see there the people who gave the vaccines. But unfortunately, the year 2 and importantly, Aboriginal children in that first year cohort, so part of a universal campaign, got equivalent coverage, but when we look in the second year, we only got 30% coverage. So there's more work to be done, and this gets down to who's responsible. Is it the hospital? They'll vaccinate anyone who's got a risk condition. Is it the GP who might be seeing them for their routine vaccinations and is not clued into the fact that they should be also getting RSV, because the hospital would have done it surely if they needed it. So I think this is important, and you can just see in the graph the gradual uptake, really, and this is the epidemiological week, so starting in the first week in April through to the end of August. We still have an ongoing program in the north, in the Kimberley and Pilbara regions, where they get a tropical peak that's in sort of February to March, as well as a winter peak. So Ushma Wadia is one of the fellows in our group who has submitted this study for publication, looking at effectiveness, again, using this test negative design approach. And you can see here that similar to the Argentinian study, we had high levels of effectiveness for nirsevimab, and the studies in Europe of over 80%. The year 2 cohort was rather small, so I think it's got very wide confidence intervals. I suspect we will see a similar number when we get more children this year, as this is an ongoing research cohort. And we also were able to show a reduction in those children who needed oxygen or ventilatory support. So very reassuring in an Australian context. If we look at the whole population, you can see here in red is 2024 compared to the previous 2 years, and you can see where the campaign started. We'd already had a few cases, but overall we had 60% less cases than in 2023. And a few less than 2022. And so if you, and there was no decrease in, and this is shown here, the number of cases in 1 to 4 year olds. So 2024 for 1 to 4 year olds was actually a worse year than the year before. So over 1,000 admissions in that cohort. And you can see generally we get more admissions in infants than we do in the 1 to 4 years combined. So this is why infants are such an important group. So we would have expected over 1,000 cases in 2024 if we hadn't had the program. And we got 378. So that's almost 700 less cases. So as a paediatrician, this is one of the few times I could say to my colleagues, you've had an easier winter than you normally did. They didn't necessarily agree, but, and I think a lot of GPs actually said the same. We got to have lunch this year and they felt there was less burden from all these small babies coming in with respiratory infections. And so this would equate to, for every 34 babies you immunise, you get a less hospitalisation. So these are the numbers we are wanting to get to when we have a combined maternal immunisation monoclonal antibody program. Important to say it was very safe. We didn't have any severe adverse events related to vaccination. And in fact, most symptoms reported after nirsevimab were due to the concurrent vaccinations they received at the time. So you can give these monoclonal antibodies with any other vaccine because it's passive immunity. And that's why it doesn't cause much in the way of side effects. And so it was estimated to save WA Health $9 million alone. So just WA Health hospitalisations on that basis. So it almost paid for the whole campaign. So that was a very... it was very well received, and in fact the Public Health and the Children's Hospital Organisation got an award from the Director General in WA for the best public health intervention for 2024. There's another one coming down the road. Merck have got clesrovimab, which is directed against site 4. Again, very high levels of neutralising antibody. This is both in pre and post-F fusion protein, so maybe we wouldn't have expected to be as effective. But when we look at the results of the phase 3 trials, this was presented at the ACIP meeting in October and presented at ID Week. You can see against hospitalisation in a randomised controlled trial, 90% protection and very high rates against the more severe indicators, but relatively modest protection against having a lower respiratory tract infection with only one indicator of severity, which it was 60%. And if we look at the nirsevimab studies, they tended to have 2 indicators, so it's probably somewhere between 60 to 80%. And importantly, it had an overall impact on any RSV respiratory infection. And there's a thought that this may get better into the nasal, better penetration into nasal tissue, so maybe does protect you more against upper respiratory infections due to RSV, but that remains to be seen. As I said, it's and this was in no difference between preterm and term infants in this efficacy, so highly effective. So just going back to these recommendations, so no question, Brisvo, the maternal RSV vaccine, is safe and effective. We want to have good safety surveillance, particularly for prematurity and related adverse outcomes, but nothing to concern us to date. But how do then we use give the choice to parents about which would they prefer for their child in terms of a monoclonal antibody that also works as good, if not better, that they can get when their child is born. And I think that's a nuanced conversation. So I think from a programmatic approach, you say everyone gets the maternal vaccination and we use the monoclonal antibody to mop up those children who don't get vaccinated or have risk factors that make them more likely to have severe disease. I would probably add those children that are born in October, November, December, who will be waning antibodies at the start of the RSV season, and I think that's the way WA will go. And perhaps we should give everyone the choice. But I think that's probably going to be a difficult point, and perhaps we can talk about that in the discussion. And I think everyone would agree that giving these other children who do have severe risk factors for severe RSV disease a second shot in their second year is critical, and I think we need to do better than we did this year, but that's a learning from us, I think. If you do want to find out more, and this is from the ResVinet Foundation based in Europe, it's a not-for-profit global organisation that promotes it. It's got a great, if you want to find out any information about RSV vaccines, monoclonal antibodies, disease burden, and they've just launched this learning hub that's actually specifically designed for healthcare professionals who have no experience with RSV. So there's one for midwives, there's one for nurses, one for general practitioners. You can scan the QR code or just type in ResVinet Learning Hub, it comes up. There's no other ResVinets on the net. And they also have one for parents. So I think there's a lot of information out there, but I think as policymakers and public health officials, we need to get this information out to families now. So I'm not hearing a lot about maternal RSV immunisation in the news, talking to colleagues, so I think this is something that we need to really focus on. So this is just to summarise. RSV is a big deal for infants and causes short and long-term morbidity, much more likely to end up with recurrent wheezing illnesses if you have RSV as an infant. We have 2 highly effective and safe approaches to protect them. We should be able to have a significant impact across Australia on RSV as we were able to do in WA this year. But it really requires a coordinated approach in communication, provision of vaccines and immunisations, monoclonal antibodies, with clear communications to the family, whatever that's decided. And I think that's why we haven't heard, because people are still trying to work out what that communication is going to be. I think achieving high coverage may be challenging for RSV, certainly this year, and we need to obviously monitor it very closely. And I'm pleased we have FluCan as a way that we can do that on a national scale for children admitted with RSV. Just to acknowledge all the people who have contributed to this in our research group and those in public health, and that's our public health team getting the award, and we'll be happy to answer any questions after the next talk. Thank you.
We're going to have a panel discussion, but just as Michael's coming up, there's a question, Peter, protection duration for babies at risk of severe disease with the monoclonal.
Yeah, so I think what we know for protection with the monoclonal antibody is that most of the studies were done to 5 months, not 6 months. There was some indication in the efficacy study in Africa that actually perhaps it's longer, that you still have circulating monoclonal antibody out to maybe 9 months. But the recommendation is for revaccination after 6 months if they're in a high-risk group, and that's what we've chosen with Aboriginal children living in the tropics of WA, for instance. But 6 months, 5 or 6 months should give you protection for the RSV season.